We go. So welcome to this session on adolescent health and well-being. Oh, I've also been told to say that there's water at the back if you'd like water. It's not on your tables, but it's there. Shane's just getting some right now, leading by example, which is great. And yeah, welcome to this session. My name's Simon Shawley. I'm currently Acting Deputy Director for International Programs at UNICEF Canada. And I'm very privileged to be joined by my colleagues across the different agencies. We have Emmanuel Guidebo, Technical Specialist for World Vision Canada. We've got Colleen Keelty, Monitoring and Evaluation Advisor for Plan International Canada. And Dominique La Rochelle, Senior Gender Equality Advisor for Save the Children Canada. And the kind of the format of this kind of session, we want to keep it quite free-flowing and informal. I'll just be presenting for the first few minutes on some of the technical innovations that UNICEF and our partners are looking at in terms of how we improve adolescent health and well-being. But obviously innovation is not just limited to the technical side. We also want to be looking at how are we programming innovatively. So then I'll hand over to my colleagues who will go into a bit more detail on a specific Canadian-supported project around preterm birth. And then we'll have some kind of discussion between ourselves, and then we'll open it up to you for a substantive portion of the session to ask all the tough questions that we don't have any of the answers to. So I'd really encourage you, as we're talking, to really be thinking of the questions that you would like to ask, and yeah, we'll go from there. So do come on in, everybody. There's some seats right here at the front, so you'll be very welcome to take those. So I guess being at the conference that we're in and with the audience that we have today, there doesn't need to be too much introduction around adolescents. But I just thought I'd give a couple of high notes that from UNICEF's perspective we see as the key demographic influences. I mean, today we have about 1.2 billion adolescents around the world in the age ranges of 10 to 19. And generally speaking, we're seeing that they're the healthiest generation of adolescents that we've seen ever. And a lot of that is due to the progress on things like the Millennium Development Goals, in terms of halving child mortality, in terms of nearly halving maternal mortality, in terms of looking at the improvements that we've been managed to make around HIV/AIDS and other issues. But we're still seeing, every year, we're still seeing 1.3 million preventable deaths of adolescents around the world. And that's indicative of a gender disaggregated I guess, scenario for adolescence. Whereas for boys, adolescence is seen as an era of opportunity. For girls, adolescence is seen as an area or a period of uncertainty. We all know the factors that contribute to this. UNICEF's recent Gender Action Plan really aligns with what the Government of Canada's Feminist International Assistance Policy has identified in terms of the key factors such as nutrition, whether it's undernutrition or increasingly in middle-income countries is overnutrition or obesity. Pregnancy care, which we'll go on to in a bit, HIV/AIDS, gender-based violence, menstrual hygiene management, child marriage. All of these key factors are influencing adolescent health and well-being. If we take the example of HIV/AIDS, for example, we've got 2.1 million adolescents who are currently living with HIV/AIDS. And the adolescents age demographic is the only group where we're seeing an increase in HIV infections around the world. And so as Peter Singer was mentioning in the opening plenary session, business as usual is not good enough. We can and we have to do better. Business as usual is not going to be good enough to help us achieve the SDGs. Business as usual is not good enough to fill the $2.5 trillion funding gap that is there in order to achieve the SDGs. And business as usual is not good enough in terms of how we program and how we reach young people, one of the points that Stanley was making in the opening session. And so we really need to innovate. And, you know, I echo Peter's comments. It's great to see innovation institutionalized in the Government of Canada's response to development issues. And like I said, innovation is not just about technical innovation. It's how we do things differently to achieve better results for more women and children at a faster pace. And so I just want to take you through a couple of the innovations that we are looking at to kind of inspire you, to kind of think outside the box. This isn't traditionally how we do things, but this is potentially what is working. So the first I want to talk about is I want to take you to Malawi. And Michael very kindly took us on a helicopter ride and a spaceship ride. I want to take you on a drone ride. Malawi, I don't know if you know, has one of the highest HIV prevalence rates in the world. Nearly 10% of people in Malawi are living with HIV/AIDS. 48,000 people die from HIV/AIDS in Malawi every year, and 10,000 of those are children. 40,000 children are born to mothers who are HIV positive. And so we really need to look at innovative ways of addressing that challenge. And early care depends on early diagnosis. And that means transporting blood samples from the health centers or the health workers to the laboratories where we can get the test results. But because of the infrastructure, because of the difficult conditions that we have in Malawi, because of the costs of transportation, it can take up to 60 days from when a mother or a child is tested to when they get the results back. And that has a direct impact on women's and children's health. And so our task as UN agencies and our partners is around how do we reduce the transportation time and increase early treatment. So UNICEF, together with the Ministry of Health and the Civil Aviation Authority, launched the world's first humanitarian drone corridor. And this was centered at the Kasungu Aerodrome, which is about an hour and a half outside the capital, and the hospital there. It's got about a 40-kilometer radius, and we're doing a testing ground over about 5,000 square kilometers. The drones work up to about an altitude of 400 meters. And we're doing a 2-year rolling program of testing for drone-based interventions around HIV/AIDS. And we collaborated with several private sector companies to design a drone specifically adapted to transport these test results in a safe conditions to the lab and back. It's been very exciting. We've had to do a lot of social norms and behavior change communication to inform the communities about what the drones are doing and what they're not doing. But we've seen great results so far. We've managed to half the time of lab results return from 60 days to 30 days, and we're looking to reduce that even further. We're also looking at other uses for those drones, so things like transporting vaccines, things like if there was a flood or an emergency, could it provide short-term connectivity through a router based in the drone so that we could connect people with the Wi-Fi and the cell phone signals. And also, in the most recent cholera outbreak, we've used it to monitor cholera outbreaks among specific wash facilities. So once we locate the distinctive water or sanitation points, we can then see which of those are linked to the cholera outbreak, and we can then target our limited resources to addressing our response in that particular area. And we're currently working to then see, is this relevant in other scenarios? We currently have a request for tender out for vaccine transportation using drones in Vanuatu in the Pacific Islands. And just recently I had the privilege of leading a pharmaceutical workshop kind of looking at solutions that the industry could provide to us. So I just want to inspire you, think outside the box. That's one idea of where we're using innovative technology to better adolescent health and well-being. The second place I want to take you is to Zambia. And Zambia, we're really focusing in on menstrual hygiene management and looking at how do we take an integrated, innovative approach to menstrual hygiene management. As most of you will probably know, poor menstrual hygiene management has an adverse effect on girls' education and health outcomes, particularly around cultural stigma, lack of knowledge, lack of social support, lack of actual materials, and lack of adequate and gender disaggregated water and sanitation facilities. This has led to an increasing dropout at secondary school level. So the average attendance rate at primary school level in Zambia is around 82%, but in secondary school level that is literally halved to around 41% of girls who are attending secondary school. And one of the key contributing factors is around menstrual hygiene. So our task as UNICEF and our partners is around looking at how do we take an integrated innovation approach to make sure that girls can better manage their menstrual hygiene and that we can integrate this into health and education systems. So in 2014, with Canadian government support, UNICEF and partners We supported a Wash in Schools for Girls program in 14 countries, including Zambia, and that included the rollout of both government guidelines and a school toolkit. The toolkit was successful in 30 schools piloted, so we rolled it out with the help of the UK government to 200 schools, and now we're looking to transition that to national scale. And the three aims were around increasing awareness, increasing supplies, and improving monitoring and evaluation. And we've seen great results in terms of how we approach it from a gender-responsive approach. We've managed to, in the pilot communities, break the social taboos around menstrual hygiene management by having boys and girls in the same room, discussing this openly, helping to reduce the stigma and the shame that is often associated with menstrual hygiene. The particular role of male teachers and students is really important. And as you see from a couple of the photos here, we've actually worked with them to co-design menstrual materials from materials that are locally sourced, that are renewable, that are sustainable, that are low cost. And that's seen great support at the village and community level. We've involved mothers groups and parent-teacher associations, and are looking at how do you develop these into social enterprises so that they're at least revenue neutral, if not actually income generating for the communities. So those are just some of the things that we've been working on. And finally, transferring from the annual paper-based 27-page monitoring form that every school has to complete to a mobile-to-web system where teachers have to report just on 11 key indicators, which includes menstrual hygiene and the suitability of wash facilities in those countries. And we're seeing a big uptake in that with the company that we're working with there called Across, and you can see their link right there. So that's just, again, an example of an integrated approach, and one that we're now looking to take to scale nationally. And finally, talking about cell phones, looking at how do we make sexuality education available for free to adolescents in some of the most important and most high-burden countries in the South. As you'll know, inequality in South Africa is both pervasive and it's gendered. Adolescent girls are disproportionately affected by everything from safety concerns to alcoholism to drug use to pregnancy and HIV/AIDS. 1 in 4 girls is reportedly sexually abused. And of all the sexual abuse cases in South Africa, 40% of those involve children. We have 2,000 adolescent girls who have been infected with HIV/AIDS every week in South Africa. And the prevalence is 8 times higher amongst girls than amongst boys. And that speaks to the phenomenon of older male partners and girls being coerced into forced sexual intercourse because of income, because of social pressure in terms of accessing education, as we heard a brief example in the plenary already. And we're seeing as one of the root causes is a lack of information that adolescent girls have. A lack of information about their sexuality, about testing, about what's available to them, and then about treatment. So our task is to overcome these barriers. How do we provide adolescent girls with content that's easily accessible, that is relevant to them, but also is free? And so we've been working again with the private sector on something we call the Internet of Good Things, which is around mobile-ready resources, which is made free via our distribution partners, which means there's no data charges for the young people accessing it. It's currently live in 62 countries and is compatible across 80% of cell and mobile phone devices. The content is translated, it's adapted, it's localized for the young people. And in South Africa so far, we've reached over 400,000 adolescents in the first phase. And instead of me just talking about it, I'd really encourage you, have a look at the web link. It's supposed to be designed for old as well as new school phones. Have a look at what we're saying, what we're providing to the young people, and also what they're saying, because there's an interactive link there. So a very rapid-fire journey across innovations for adolescent health and well-being in sub-Saharan Africa. But like I said, innovation doesn't have to be technological. It can also be how are we programming for adolescent girls across our different contexts. And so with that, I'd like to hand over to Emmanuel, and you can introduce us to the Born on Time program and what you and your partners are doing there.
Thank you, Peter. Yeah, Born on Time it isn't primarily an adolescent sexual reproductive health initiative, but it has significant adolescent sexual reproductive health programming. So it's an initiative that's a 5-year initiative launched towards end of 2016 in response to the global call for action by the WHO's Born Too Soon report, which highlighted the global burden of the prevalence of preterm births, which is currently the leading cause of child mortality, accounting for 16% of all deaths among children under 5, and nearly 1/3 of mortality among newborns. So to put this in perspective, every year, globally, 15 million newborns or 15 million children are born prematurely. So that's a global burden. That's a significant one. So that means children who are born prematurely are starting their life at a significant disadvantage. And I just want to actually make a quick connection to the whole of life map on the discussion paper, because this presents a challenge right at the beginning of this whole of life map. So I actually want to make an argument that the whole of life approach should include interventions targeting prematurity. I haven't seen one, but it's a discussion paper, and hopefully that will be considered. So the initiative is formed as a partnership between 2 donors, the Government of Canada and Johnson & Johnson, a private donor, and then a consortium of 3 Canadian NGOs, World Vision Canada, Plan International Canada, and Save the Children Canada. So in a way, it's also a public-private partnership, which I think is one of the innovative ways of financing the SDGs. It's being implemented in 3 countries, Bangladesh by Plan International Canada, in Ethiopia by World Vision Canada, and in Mali by Save the Children Canada, focusing on prevention. I want to underline on that. It's primarily about prevention of the risk factors of preterm births related to 4 key areas of risk. That is lifestyle, infection among mothers, nutrition, and contraception, targeting primarily women and adolescent girls before and during pregnancy. Just a few words on the risk factors. Lifestyle has emerged as being one of the key factors in health, and this is not a surprise. And of course, with the social determinants of health, now we know that lifestyle is a key. And then when it comes to the issue of preterm births, there are certain key risk factors, things like intimate partner violence, which literatures have shown to have been associated with increased risk of preterm births with 91% increased risk compared to people who are not faced with that type of violence. And to give an example on the infection-related risk factors, Peter mentioned about how prevalent sexually transmitted infections, including HIV, are, especially among adolescents. So with 2.1 million living with HIV. So HIV is associated with 83% increased risk for preterm births. So that's a significant one, and same with other STIs like syphilis, which in fact increases the risk twice, literally doubles the risk. And then on nutrition, just to give one example, maternal anemia increases the risk of preterm births by 95%. And then on the contraception, focusing primarily on the timing or spacing of pregnancy, again, linking it back to the adolescent sexual reproductive health, adolescent pregnancy increases the risk of preterm births by 93%. Again, another significant risk there. So while adolescents are at greater risk of all of these four categories of risk factors for preterm births, in fact, they are also at greater risk of some of the lifestyle risk factors. And the WHO report shows that according to WHO reports, the mass majority of adolescents who are using drugs, tobacco, alcohol, they start that at least 1 in 10 of those adolescents start that at in the age range of 13 to 15, which means there is a significant another lifestyle risk factor there. So just to give you some high-level global statistics as well as country-level statistics on these risk factors, for example, when it comes to contraceptive use among adolescents who are either married or in union, looking at the 3 countries that we work in, Bangladesh, Mali, and Ethiopia, between 53% and 93% of these married adolescents are not using any form of contraceptives. That means they are literally exposed to teenage pregnancy, which is a key risk factor. Again, all the 3 born-on-time countries are among the 20 top countries with the highest rates of teenage pregnancy. Just to give you some statistics on that again, Mali being the 4th with 55% teenage pregnancy rates, and Bangladesh at the 6th place with 52% teenage pregnancy rates. So that means adolescents are at the center of the issue of preterm births here. Another important statistics is that still poor birth outcomes such as stillbirths and deaths among newborns are at 50% higher rate among young mothers who are below the age of 20 compared to their older counterparts who are in the age range of 20 to 29. So that's a significant risk. And adolescent girls are also at greater risk of STIs, as I mentioned before. And then rate of preterm births, low birth weight, and asphyxia, which are all complications of newborn and primarily prevalent among premature babies, are the highest amongst the children, babies born to adolescent girls. And then teenage pregnancies are associated, as I mentioned it earlier, with 93% increased rates of pregnancy. So these are some of the statistics that informed our design of interventions for born on time. And then coming to what we do on the ground, we take 3-pillar approaches in born on time. And this isn't unique. These are the common approaches that we take in maternal and child health programming, the demand side, the supply side. And then another important element that we looked at in born on time is the data aspect. The strengthening data collection and utilization for decision-making purposes, especially knowing that there is significant information gap in the area of preterm births. And one of the key gaps that's highlighted by the Born Too Soon report was that there is significant data gap when it comes to the issue of preterm births at country level. And many of the global statistics are based on modeling and statistics that are based on hospital data. So for that reason, we have put significant emphasis on strengthening data collection and utilization. So when it comes to improving the availability of health services, in general, we are looking at 3 key interventions. That is training of healthcare providers, building their capacity and their skills in providing those services, improving local health facilities, equipping them with some key supplies and equipments, and then strengthening referral systems. And then coming down to the issue of adolescent sexual reproductive health, in this area of improving availability of services, again, there are some key areas that we focus on: training health workers on the provision of adolescent-friendly sexual reproductive health services. There are some WHO criteria, domain of criteria on what that means. If we get the time, we can briefly visit that later. And then equipping the health facilities to provide adolescents friendly sexual and reproductive health services, again, with some basic supplies and equipments, and also minor innovations to help the health facilities have some adolescent-friendly spaces in their facilities. And then, of course, availability of information is key. In most cases, adolescents don't know what type of services are available to them. Helping the health facilities make that information readily available to adolescents is the other key area of intervention in that bigger goal of making health services available to adolescents. The other and the second major area of programming is increasing the uptake of services. Again, you are familiar with the demand side. It's basically about promoting behavioral change and also tackling the issues of gender inequality. So when it comes to behavioral change, we work very closely with community leaders, religious leaders in promoting behavioral change on the issues of lifestyle and taboos. And earlier I mentioned that some lifestyle risk factors are among the key risk factors for preterm births. And then, of course, the other area would be improving the uptake of the key maternal and newborn health, as well as sexual reproductive health services, antenatal care, family planning, and newborn care services for premature babies. Tackling the issue of gender inequality is a key area of programming for Born on Time. I mentioned intimate partner violence as being one of the key risk factors earlier, which is a major gender inequality issue. So empowering women, building negotiation skills, leadership skills, engaging men in making positive behavioral change are some of the key approaches that we use in Born on Time. So when it comes to adolescents, creating awareness amongst adolescents on the availability of sexual reproductive health services, some of the adolescent sexual reproductive health issues through various platforms, including health clubs in the schools, using community-level platforms such as community health worker systems are some of the approaches that we are using across the 3 countries. And then also empowering adolescents to seek or even demand sexual reproductive health services, and wherever possible, help them participate in the decision-making processes in what type of health services and how, sexual reproductive health services and how those are provided in the health facilities in their communities. And then the third area, as I mentioned, is strengthening the data availability and utilization. And as I said, this is key given the fact that there is significant data gap in the area of preterm births, and this has been clearly identified. Of course, we struggle with data gap in across all aspects of maternal newborn health or sexual reproductive health, but when it comes to preterm births or the issue of prematurity, this is an area, just like adolescent sexual reproductive health, this is an area that has gotten global attention more recently. That means data wasn't being tracked in this area as part of the health management information system or the district health information system, whatever it's called in the country. So information wasn't being systematically tracked in these 2 areas. As a result, we are primarily working at the local level, and in some places we found it to be quite challenging to advocate at the national level because some of these HMIS systems have already been set. So we started working at the grassroots level to build the case for us to advocate nationally. So it's a key area. So just to mention a couple of things that we do on adolescent sexual reproductive health. Baseline data collection, we have we tried to inform our programming using baseline data collection. We are testing some innovative data collection tools amongst adolescents, and we are also supporting health facilities to integrate some indicators for tracking the uptake of adolescent sexual, track the uptake of adolescent sexual reproductive health services. And finally, I want to highlight that the intervention of or the programming of Born on Time across the 3 countries, it actually cuts across sectors. So we are not limited to the health sector, but we actually work with sectors outside of health, ministries of women's affairs, ministries of education. So I think that connects to the discussion on intersectionality and the multi-sector approach we need to take moving forward. And hopefully Born on Time's experience on this will inform the discussion around this.
All right. Thanks, Emmanuel. And yeah, I'd really echo that in terms of our experience of taking the multi-sector approach. It's so often easy to work in silos, and as we've worked in other countries to integrate key indicators into health and education management information systems, it's how do we work across the silos and get those key indicators, whether it's child protection, whether it's health, whether it's school dropouts, into the same system. So that we're not asking frontline workers to fill in multiple forms, to do the same job over and over again for slightly different audiences. But before we go on to the data collection and looking more into that, Dominique, maybe perhaps you could address how your program is being very gender responsive in terms of its programming.
Yeah, thank you. Good morning. So yeah, I'll take about 5 minutes just to walk through the process we have undertaken within Born on Time to make sure that gender equality was not an afterthought, not something that we would realize halfway through program implementation that we forgot to do, but something that has been really at the forefront and at the center of this approach. Because as Emmanuel mentioned, all these risk factors of preterm birth, they're all influenced by gender inequalities, right? Contraception, we cannot just give contraceptives to women and girls and think that they will magically start using them. There's a lot of power dynamics that influence the uptake of contraceptives. So we really need to look into these gender inequalities, these norms, if we want our interventions to really have an impact and be sustainable. So that's why it was very clear for us within the Born on Time Consortium, within the 3 organizations, we were all on the same page back in 2015 when we started developing this project proposal together. We wanted Born on Time to be a good example of an integrated program that integrates health and gender equality. We wanted it to be gender transformative as much as possible and be gender responsive at a minimum. So what we did was really interesting. So we were, the 3 of us, the 3 organizations in these 3 countries, we had been working in these 3 countries already on MNCH programs. We had been working on gender equality dimensions of MNCH programs as well. So we had a lot of knowledge about the different norms and inequalities that were present in these countries and that could have an impact on any preterm birth prevention program. So we had that body of knowledge. So we worked with our gender equality advisors in the field, we did a literature review, and we created a gender equality strategy for Born on Time. So that strategy had kind of 2 main parts. So the first part was basically a review and a list of the norms and gender inequalities that were present in all the 3 countries and that we knew had an impact on preterm birth, but also on gender equality in general and the human rights of women and girls. So we looked at that in the 3 countries. The issues were very similar, even if sometimes they are manifested differently, they all come back to discrimination against women and girls. So we found a lot of common issues that are very much relevant to preterm birth. So for example, very high prevalence of child early and forced marriage in all 3 countries, high rates of teenage pregnancy, as Emmanuel mentioned, high rates of intimate partner violence. We also observed very limited decision-making power for women and girls in all spheres of their lives, whether it's about health-seeking behavior, whether it's about spending money, whether it's about making decisions on the use of contraceptives. So that obviously has a big impact on an issue like preterm birth. We also notice a lot of knowledge gaps amongst women and girls, but also men and boys on sexual and reproductive health. And we also noticed a lot of cultural and social taboos and myths and beliefs that would also influence our interventions. So that was the first part of our gender equality strategy, which was quite a lot of work. But the second part was even more challenging, was to really look at all these inequalities and look at, okay, so what do we do? What shall we be doing to address these inequalities within our program? Because if we don't do this, then there's high chances that our programmatic approaches to preterm birth preventions would be much less efficient. So we have, developed, kind of tried to regroup our interventions into kind of three main areas of interventions of our gender equality strategy. So yeah, we have them on the screen. So the first area of our efforts is really about supporting the empowerment of women and girls. So I will talk about that a little later, but it's, a lot of our interventions is about, for example, creating clubs for adolescent girls where they can, learn about decision making, leadership skills, and all of these things so that, we can support their empowerment. We have a big chunk of our efforts that are about engaging men and boys as active partners of change. That's obviously very, very important to shift norms and behaviors around harmful practices such as child marriage, for example. And the third part, which is equally as important, is about engendering newborn and reproductive health services. So basically making these services more gender responsive, right? To make sure that facility-based healthcare providers, community health workers, that they're not judgmental if adolescents come to them and ask them for advice on contraception. So really addressing these norms that are very much present at the health system level. So we have a lot of interventions around these three areas. So that was the second part of our gender equality strategy that we are now implementing within Born on Time. Something else we did to make sure that this gender equality strategy was good and accurate and evidence-based is that when we started the program, in the first year, we had that huge baseline study that Colleen will talk to us about. And within that baseline study, we had a specific gender equality assessment that enabled us to really go back to the communities where we're working and really test our assumptions. Was our initial understanding of gender equality dimensions, power dynamics, was that accurate? Are the interventions we're doing good enough to address them? So we kind of looked at these questions during the baseline process, and we were very lucky that our findings basically confirm our initial understanding. I think it did provide us maybe with additional contextual information in some places to have even better targeted interventions. In Malawi, for example, I think we had underestimated a little bit the impact of polygamy on all of this. So that's something now we're really looking into more seriously. So that's something we have done to test the validity and relevance of that gender equality strategy. Now we are implementing it and we're monitoring it very carefully to make sure that we do not create harm, right? Because when we have these gender transformative interventions, sometimes if we shift power dynamics too quick, if we don't monitor some important aspects that we didn't see, that can create harm. So that's something we're doing as well to monitor, making sure that our interventions are doing what they're supposed to do. So I'll end here for now. I think this was just to give you an overview of how we do it and explaining to you how this program is really an integrated program that has been gender transformative since day one, and we're very proud that it's also contributing to the implementation of the Feminist International Assistance Policy.
Great, thanks Dominique. And now over to Colleen to kind of address that a bit further in terms of how you then monitor and involve young people.
Sure. So I'll just build off of Emmanuel and Dominique's contributions, and thanks for that, and good morning to everyone. Just by talking really briefly about measurement challenges in a project like Born on Time, and specifically for adolescent populations. So I'll start by just framing that discussion around some of the well-known challenges to measurement with adolescent girls and boys, and then talk a little bit about the different steps that Born on Time has taken to try to navigate those waters. So first, I think it goes without saying for implementers and M&E folks like myself alike that adolescent sexually reproductive health programs are complex. They can be multi-sectoral, as we've talked about, and that presents unique challenges to M&E. Furthermore, adolescents as primary respondents in our M&E processes also present their own unique needs and challenges. So we know that there are many factors that influence adolescents' behavior. Those can sometimes be difficult to measure, and then change in those behaviors can be difficult to attribute to a single project's interventions. We also know that ASRH topics can be highly sensitive. They're considered personal or private matters, and in some contexts, we're prohibited from talking about them. So that means we have to take really special consideration for informed consent and assent from our participants in terms of parental consent, and then also really carefully consider what do we need to do to ensure optimal privacy and confidentiality for our respondents. How do we mitigate risks to emotional safety and risk of disclosure? We also know that the age range that we're often talking about is 10 to 19, so that's a really wide range of educational levels in terms of comprehension of some of the topics we're talking about. So our measurement approaches need to be customized for the lower and upper ranges there. And then finally, access to adolescent populations is sometimes difficult. They're not always available at the household. If we find them at schools, we introduce some bias to our sample because we're missing those adolescents who are outside of school. So lots of challenges to work with that should not be a surprise to many of you. And even when we carefully consider all of those challenges in our measurement plans, we still find that most commonly sexual activity and related behaviors continue to be underreported. Most of the available data we have, including from DHS, is for the 15 to 19-year-old age range, and that's often just for adolescents who've had a live birth in the last 2 years, because that's the core focus of some of those surveys. So we're really missing data, especially on younger adolescents, which prompts us to use retrospective data for that group, and for adolescents who've never had a child. So how did Born on Time navigate all of those challenges to measurement? I'll talk first about our kind of core approach at the baseline, and then some additional methods we've been testing, as Emmanuel alluded to, specifically for adolescents without a child. So at baseline, we conducted a household survey, as many of you do in your MNH and SRH projects. We included adolescent mothers with a live birth in the last 2 years and drew from the standard modules of the DHS to do that. As Dominique mentioned, we also conducted a fairly thorough gender and adolescent assessment, and that included focus group discussions with adolescents married and unmarried in groups segregated by sex and marital status to really draw out those unique perspectives of adolescents who fall into those categories and do a little bit of subgroup analysis on their needs with regards to sexual reproductive health. And then finally, as Emmanuel mentioned, we conducted a health facility assessment in a sample of health facilities. And what we were looking for as part of that assessment was the adolescent friendliness of facility service provision. And to do that, we adapted the WHO's global standards for quality healthcare services for adolescents, which I'm sure many of you are familiar with. From those 8 standards and criteria, we chose 4 that were most relevant to Born on Time's interventions. So those include provider competency, facility characteristics, an appropriate package of services available to adolescents, and then adolescent health literacy. So while that approach sounds like it should be fairly comprehensive, you'll notice that we had very little data from adolescents without a child. And they were not included in the baseline for 2 reasons. So the first is that there is no internationally validated or standard tool for adolescents under the age of 15. DHS and MICS are looking at adolescents 15 to 19. That's what those tools are designed for. So we didn't feel it was appropriate to include that younger age group in a tool that wasn't necessarily meant for them. And the second was that we expected that considering sexual activity and related behaviors is often underreported, we wanted to move this exercise outside of the household. That would provide optimal privacy and confidentiality, especially for our younger respondents, and hopefully mitigate some of those other response bias issues. So to address this group, adolescents without a child, we've recently piloted what's called an ACASI survey. So that's an auto computer-assisted self-interview survey, and we recently did that in Bangladesh. That covered a variety of SRH topics, which included menstrual hygiene management, SRH knowledge and practices, attitudes towards early pregnancy and marriage, et cetera, among others. That was conducted outside of the household. It again provided that increased privacy and confidentiality for respondents since it was self-completed. And additionally, we were able to add an audio component to that survey so that each question and each response option was available in an audio recording customized for a male or female respondent. And that meant that we could potentially include those younger adolescents who might have lower literacy levels and be unable to self-complete a survey that needed to be read in full. So considering all of those approaches, we've tried to address some of these challenges for adolescents both with and without child and born on time, especially considering that this project, while it includes adolescents, really has a focus on prevention of preterm birth, especially in the antenatal care period. So while we're recognizing that that still needs to be maintained as the core focus of our measurement approach, we've really tried to integrate other methods for reaching those other beneficiaries of the project.
Thanks, Colleen. I don't know about you, I find it fascinating. I have so many questions, but you guys start to prepare your questions and also be thinking about, you might be thinking, sure, this is interesting in this project, but what about where I'm working? So maybe think about questions or points around the lessons that could be learned from these. But before we turn it over to the audience, I just thought, maybe to all of you really, kind of what are the similarities and differences in terms of the successes and the challenges that you faced across the three countries? I mean, Emmanuel, you gave us some idea as to why you chose those three countries in terms of the high prevalence rates, but they're also very diverse. So maybe just give us an indication of some of the similarities and differences in what you've managed to achieve so far, but also in terms of the challenges that you faced. I'll let one of you go first.
Yeah, let me highlight a few things from the health systems, the formal health systems perspective. When we embarked on the implementation, especially in our attempt to better understand the needs around adolescent sexual reproductive health, in addition to the surveys, we've tried to do some mapping of the landscape, the policy landscape in all of these three countries, whether there are some national strategies and guidelines for implementation of adolescent sexual reproductive health, some minimum standards, some defined service packages, some standards for the health facilities. We've a couple of times mentioned about the adolescent friendliness criteria. So what we learned from that exercise is that the three countries are at completely different stages in their rollout of the adolescent sexual reproductive health. What that means for us is that we can't really do, the same type of approach across the three countries. So to just highlight some of those differences, in Mali and in Bangladesh and in Ethiopia, there are some national strategies and guidelines. The countries have also adopted the adolescent friendliness criteria that is recommended by the WHO, which is all good. It gives us the policy and strategy framework to operate in. But when it comes to working with the health facilities at the grassroots level, what we are learning is that there is a huge gap between the policy and the practice on the ground. And most of the services in the health facilities on adolescent sexual reproductive health are being supported and driven by NGOs rather than the government, the Ministry of Health structure on the ground. And in some cases, the health facilities haven't even thought about making their health facility adolescent friendly, or they don't even seem to know what those standards are. In a handful of health facilities have started implementing that, including finding a dedicated space for providing adolescent sexual reproductive health services with some, to give some privacy to adolescents, defining some service hours for adolescents, having a dedicated department and dedicated staff, but the majority of the health facilities haven't started it. So that's a major policy / practice gap. In Mali, it's a bit unique. The country is still in the process of developing, articulating its national strategy and implementation guidelines. So there is an opportunity there for us to support that process and inform that process, even from child health perspective, like the issue of preterm births. So it's a challenge and also an opportunity for us in Mali. So yeah, so briefly, that's the difference we can see from the formal health systems perspective. But of course, this being a totally different contexts. As we said, we were looking for contextual variation for the purpose of learning when we selected these 3 different contexts. We were looking for a South Asian country and then a couple of areas in Africa, and in fact, Africa itself being quite diverse. And then one of the reasons we had to look at those 2 regions is because these 2 regions have 60% of the global burden of preterm birth. So we needed to focus on the areas where the problem is, but in addition, we also had to look at the diversity in the context for learning, as well as we also needed to look at our comparative advantage on the ground to do a strong implementation, because without a strong implementation, we will not be able to learn. That included the government commitment, policy commitment, as well as our organizational presence in these 3 countries. But for the cultural variations, probably I will leave that to my colleagues. I know Dominique will say a couple of words on that.
Yeah, just following up on that and maybe looking at some of the social norms, challenges that you had to address as you look to implement.
Yeah, absolutely. So there's thank you, Simon. So there's a lot of, I was alluding to it earlier. This Born on Time is really looking at the social norms that are present in the countries where we work that discriminate against women and girls, and that can have an impact first, obviously, on their human rights, but also second, on their health outcomes. There's a lot of social norms in the community. The ones we're really trying to shift and change are those that discriminate against women and girls. We don't want to change norms for the sake of changing norms. We really want to shift and move the needle on discriminatory social norms. So there's a lot of them. We have studied them. I'm just going to share a couple of examples from the countries just so you understand, what are these social norms and where they're coming from. So we were talking about that gender equality assessment. So that assessment has revealed in all 3 countries that girls actually face a lot of pressure to marry at an age that they don't want to get married. So like kind of earlier than what they are hoping for. That's something, we have observed in all 3 countries. In Bangladesh, it was very interesting when we spoke to men and boys that they really acknowledged that the boys don't feel the same pressure than girls do to marry early. We also interviewed unmarried adolescent girls in Bangladesh who reported that there's also some pressure from the husband and his family to have children soon after marriage, which again is fueling that teenage pregnancy risk factor of preterm birth that we've spoken about. In Mali, we've seen the same thing about the pressure on newlyweds, especially those who are young, to have children soon after marriage, because in Mali that's a way for men to express their masculinity. In Mali, the men and boys we spoke to also told us that there's a lot of shame that is associated with a girl who would get pregnant before marriage. That's something we've seen in all 3 countries. So all of these norms, they really outline and highlight the control that is exercised on girls' sexuality in these 3 countries, and that fuels child marriage, that fuels teenage pregnancy, and that's a problem from a human rights point of view, obviously, but also from a preterm birth prevention point of view. So that's why we're focusing on these norms. Another social norms that we've seen across the board is norms that tend to tolerate intimate partner violence and violence against women and girls. So in Bangladesh, what we've seen is that violence is often seen as a means that can be used by the male head of household to kind of maintain order and maintain a functioning household. In Mali, we've learned that violence is often seen as legitimate when women disobey her husband, for example. However, I must say, and Colleen might provide a bit of data around that, but in a lot of these countries as well, there's a lot of people who speak against that, who are not condoning or not supporting violence. But we can't ignore those who do, and that's why we need to work on that social norm as well, because intimate partner violence is a very important risk factor of preterm birth, in addition to being a human rights violation, obviously. The last social norm I'll talk about briefly is that in 3 countries we have observed norms that tend to concentrate decision-making power within the hands of men. Of men, yes, but also or mothers-in-law. So that's been seen in all domains, when it comes to family planning, when it comes to deciding whether, when, if, how many children you want to have, deciding if you can go to the health facility, deciding if you can spend money to go to the health facility. So all of these norms, they obviously influence a lot of things, including health-seeking behaviors. So these norms also affect adolescents, I think probably even more, because they might have, because of their age, even less control over that. So we do spend a lot of time also addressing these discriminatory norms, because decision-making power is really important, obviously, in that topic, so that women and girls can decide when they want to go to the clinic, how they can spend their money, whether they want to use contraceptives, whether they want to have children. So that's another big social norm on which we're working.
Sure. So just to build on that, sorry, is my mic on? Okay. Just to build on that a little bit, I think there's a handout on your desk that includes some statistics from the Born on Time baseline, and one of them there is attitudes towards intimate partner violence. So you'll see fairly high rates of men who tolerate IPV, and that's displayed for you by country, but that's up to 70% in Malawi. So I think that just reiterates your point, Dominique, about the importance of that risk factor. I think you talked a lot about equitable decision-making practices, and I think what we saw in the baseline was that a very small proportion of adolescent girls felt that they were experiencing equitable decision-making in their household. And as you said, that's often because they felt that it depended on agreement with their male partners, or because those decisions were being taken by their parents or their parents-in-law. And the reasons that they often gave for that low decision-making power was that they felt that because they lacked a certain level of education, they weren't able to make those decisions on their own, because they lacked access or control to resources at a household level. That affected their decision-making. And obviously, these deeply rooted traditions around the influence of in-laws and the influence of elders continue to limit their decision-making power in their own sexual reproductive health. The other thing I wanted to talk about really briefly was about contraceptive use and some of the trends that we saw there. Again, I want to reiterate, this is specifically adolescents with a live birth in the last 2 years that were included in our household survey, for all the M&E folks who are going to come up and ask a question about that. We saw that it was fairly comparable, actually, to adult women who'd had a live birth in the last 2 years, but what we did find was that myths persist regarding contraceptive use, that they cause illness and that kind of thing. And that adolescents' limited knowledge about their family planning options and the side effects of family planning were exacerbating kind of those misconceptions. There's also a common belief that we saw across countries that SRH information is not required for an unmarried adolescent, and that was a big issue that we're trying to tackle. As a result of that, unmarried adolescents often need to rely on their family members or their in-laws for information about sexual and reproductive health, which again limits the realization of those rights. That being said, on a final note, what we also saw is that adolescents are reporting they're increasingly exposed to information about sexual and reproductive health from community awareness programs, from television broadcasts, radio broadcasts, and at school. So we are cautiously optimistic that we'll see improvements on that as well.
Great. Thanks, guys. I did have more questions, but I think actually let's open it up to the floor now. So if you have questions, I think there's a microphone here. I don't know. Oh, there's another one here. If you could just come, your name, your organization, and then a very brief question, please, or critique or comment, whether it's on M&E, whether it's on gender equality, the programming side, or even innovation. So,
thank you, Simon. I'm Alia Bibi. I work with Plan International Canada, part of the consortium, but excuse me for my ignorance. And if I'm stealing your question, Simon, because UNICEF is very great about it. I looked at the project that it's really focusing in changing the norms, and even the risk factors talk about changing lifestyles, and we talked about intimate partner violence, and we talked about adolescent contraception because teenage pregnancy is high. So we know adolescent is a very vulnerable age group already. And when we are trying to tackle these gender gaps, which are very huge, talking about IPV, contraception, it's even getting more, the intensity of vulnerability is getting higher. So there might be some protection and safety issues for these adolescents. So I wanted to know, how is this project addressing those protection and safety issues? Where do they seek safety, where do they go to? Because everything may not be easy when dealing with leaders and doing awareness raising. Where do they go for demanding their rights? And if they don't want to conceive, the adolescent girl doesn't want to give birth or be pregnant or getting married, where does she go to?
Great, thank you. We'll take 2 or 3 questions at a time. Someone from this side of the room?
Hi, good morning. My name is Christiana from Results Canada. I have 2 questions, but they're somewhat related, so I'll count them as one. This is for the Born on Time project. In your baseline analysis, it looks like there is a pretty significant disparity between iron supplement uptake between pregnant women in Bangladesh and the other 2 countries of Mali and Ethiopia. From your research after the fact, what had you attributed as the explanation for this disparity? And the second question is, sorry, my writing is terrible. Was iron supplement uptake the only indicator that you drew from to indicate nutrition status of the population? Or was there other indicators like food system access or diversity of foodstuff?
Great, thanks. Final question from this side, then we'll answer them, and then we'll come back to the second round.
Thank you very much for the wonderful presentations. My name is Violet Nanyu. I'm from Western Kenya. I'm with the Aga Khan Foundation and Moi University School of Medicine. My question goes to the menstrual hygiene in Zambia. I'm aware that in Eldoret in Kenya, there are efforts towards helping young girls access sanitary material that they can recycle. And so what they're working on is awareness, acceptance, and engagement, actually, of the girls and their parents in making the sanitary material. And one of the questions, one concern that has been coming up is on health issues of recycling actually a part, especially in a scenario where water, soap, and that ability to dry it on time matters. So some gynecologists are concerned that we may be pushing an intervention that may bring in new problems. And in the morning, someone talked about ethic and emic approaches to understanding what the needs of the locals are. For example, if we think access to water, just sinking a borehole, will make a difference in making this intervention a success. Is the sponsor willing to throw in a few more shillings to sink that borehole so that we make sure that girl can actually clean it and access soap and clean it properly so that she doesn't develop a new problem?
Great question. If the other questions could be patient, we'll address those first. Firstly, child protection issues around SRHR education. Does someone want to address that?
I can start.
Yeah.
So thank you for, I can see here. Yeah, hi. Thank you for this great question. So I think there's a lot of answers to that. The first one is that I think the approach we are trying to implement within Born on Time, the way it's been designed has been designed to try to mitigate these protection issues, to prevent basically these protection issues from happening in the first place. I mean, we know working on gender equality, it's sensitive. It can create harm. I think we've all heard about issues, especially, I don't know, coming with economic empowerment sometimes can create gender-based violence if that's not done properly. So I think within Born on Time, because gender equality has been so much at the forefront of our efforts, we have really worked carefully to make sure that we would work across this, what we call the socio-ecological model, or working across all levels, so that we can create change at all levels at the community at the same time. So then if an individual starts claiming their right, the other part of the community is ready to see that happening. So maybe I'll give a concrete example, empowering women and girls. So we have a lot of interventions there to support the empowerment of girls. They go to our adolescent girls clubs, our sexual and reproductive health clubs. They learn about leadership skills, decision making. They acquire a lot of information about SRHR. So that makes them, I think, I mean, from what we're observing right now, that makes them very confident. They might start claiming their rights. But what we've done to try to prevent issues from happening is that we've worked with the whole community so that there's an enabling environment that basically allows and enables girls to be able to claim their rights without safety issues, right? So we're working with community health workers, with health facilities, so they are all receiving the same messages about, girls' empowerment, about gender equality. They all receive the same messages, so we we're hopeful that it makes them kind of open to that and not, might not create backlash, because everybody's kind of on board through that socio-ecological model. So that's, I think, one way we've tried to implement from the beginning to make sure that backlash wouldn't happen. That's why we're working with religious leaders who are the gatekeepers of most of these norms, a lot of these norms in the community. We're working with other gatekeepers such as mothers-in-law, parents, role models at the community level. So that's kind of one way we've, tried to prevent that. When there are safety issues that are happening, I think, we have these adolescent clubs that are platforms that girls and boys can, raise concerns. And I won't enter into detail, but we all have our own child safeguarding and child protection systems in the field that are very well placed to address any child safeguarding issue there might be in the countries. I don't know if you want to add anything to what I'm saying.
Yeah, I think Dominique covered most of what we do around this. I think the key one is creating that enabling environment, and especially working with the community leaders, religious leaders was key. Maybe one example I can give on child protection issue. Again, maybe before that, I will take a step back. And within Born on Time, we don't really have interventions that are particularly targeting, child protection issue or some of the legal dimensions that come with it. But what we do is we have different other projects working on child protection issue, and whenever they are in geographic proximity or the same community, the projects coordinate. And I know there is this. I know this is happening in Ethiopia, and I have heard of examples where child marriage arrangements have been cancelled because of the engagement with religious leaders. But then, of course, this happened in coordination with other projects that are specifically designed to address child protection issues. So just to strengthen the point that ours is primarily creating that enabling environment, so that whenever there are child protection issues, there is a place to go, including the adolescents, the various adolescent health groups and clubs, where they get information and they know where to go. Information and the enabling environment are the two key approaches in Born on Time.
I'm just building on that from UNICEF's experience. We worked with a Canadian company in Madagascar who had experienced issues of child sexual exploitation, and one of the outcomes that resulted from that was the setting up of health kiosks where youth peer-to-peer educators were educating their peers around SRHR issues, and that actually became an informal grievance mechanism whereby young people felt it was safe to bring child protection concerns around not just the company's presence, but in terms of what else was happening in the community, and that could then be relayed confidentially and anonymously both to the first responders but also to the company itself. So something very practical and simple which worked for us was around setting up that safe space which could then appropriately relay the information to the people who needed to respond. The second question around iron supplementation, did you want to address that at all, if you can?
Sure. Maybe I'll start from a measurement perspective, and then Emmanuel, if you have any inputs about reasons for low iron supplementation in Bangladesh, please feel free. I think the question was about, did we look only at that indicator or at other indicators? And I think my answer to that is twofold. So the first is, when we were developing the performance measurement framework for Born on Time, we worked closely with Johnson & Johnson and Global Affairs Canada to develop a PMF that didn't just reflect the kind of routine M&H indicators at an intermediate or immediate outcome level, but really reflected our focus on preterm birth. And that included us prioritizing those indicators that we were working on across all three countries. So what emerged from that process was that iron supplementation was an indicator we were all working towards and would be prioritized from a measurement perspective. So that's why you'll see it in the handouts and why it figured prominently in our baseline report. That being said, when we went to design the baseline, we wanted to collect everything under the sun related to these link factors, and we ended up with like a 50 or 60-page household survey, which was unmanageable. Part of that household survey did include questions on food consumption, and on dietary diversity, and we ended up having to deprioritize some of those sections in favor of other ones on the continuum of care that were really essential for our understanding of the project. So that's to say we're interested in those things. We've collected a little bit of data on them, but iron supplements are really the priority indicator for the project.
Did you take a tiered approach in terms of having one or two of those key indicators across the broad continuum, but then maybe using focus groups or something like that to go into more detail on the other indicators or anything like that?
Yeah, I think we covered like a fairly wide range of the link factors in our focus group discussions and our key informant interviews. I'm happy to disseminate our baseline report for anyone who's interested in it. But I think out of those discussions, we really got into some of those deeper dives. But in a tool like a household survey, as many people in M&E know, those can become absolutely gargantuan. And so it's essential to really prioritize what's the essential data points that we need to report on our PMF.
Yeah. And that's what we did as well in the Zambia and the menstrual hygiene management. And just to address that last question, definitely that was a key issue in terms of how do you maintain hygiene and not create new problems when you're looking at reusable menstrual materials. That's why, as I think has been alluded to by, I think, all of us, is an integrated approach is so important. So when we were implementing the menstrual hygiene management project in Zambia, also working with the Ministry of Education, the Ministry of Health, the Ministry of Infrastructure, to make sure that the schools where we were piloting the project, there was also the simultaneous construction of the gender disaggregated wash facilities, which had a washing station, which had the adequate space and privacy and the soap and the other things that were needed to wash that, to wash the menstrual materials. What we also did as part of the toolkit, which you can find online, if you just Google wash in schools for girls, then you'll find that. It's called Wins for Girls. There was instructions in the classroom with both boys and girls as to how not only were the minimum standards around what they were making in terms of the menstrual materials, but also the washing procedures, what were the health impacts. And these were done obviously in a language that was at a relevant level to the beneficiaries, also using interactive role plays and a lot of imagery and a lot of kind of adolescent-friendly communication techniques to make sure that was addressed. There are lots of obviously other complexities around those issues, and happy to address them outside of this session. But yeah, hopefully we addressed a couple of those questions. Shall we go to the next round? Go for it.
Thank you. I'm Alessandra Rezu. I work with Humanitarian Inclusion. We work on disability. And I wanted to ask a specific question related to the monitoring and evaluation aspect of the project Born on Time. You mentioned specifically that some of the tools were designed to reach out to young girls with low literacy, and you created tools, specifically audio tools. And immediately I thought, well, this is not only for girls who have low literacy, but also girls who have visual impairments. But because, unfortunately, girls with disabilities often have barriers to reach, to go to school and have low literacy, then it is a great opportunity for including girls with disabilities in this kind of project. So my question is the project design also considering a disability lens? Is disability inclusive, and are the data disaggregated by disability? Thank you.
Thank you. At this side?
Johannes Paulus. My question is, within the framework of Leaving No One Behind, was your study did it involve key populations, people with HIV/AIDS, sex workers, and young people doing drugs?
And third question from this side?
From Aga Khan Foundation Canada. Question is for Colleen. You rightly mentioned the limitations of DHS and mix. And so I was just wondering if you could speak to more about the methodological approach for recruiting both in and out of school, because you equally highlighted the limitation or the inserting bias by going to the school. And how do we reach those adolescents out of school in a more effective way?
A lot of those are M&E questions. I'll take one more from this side of the room and see if there's something else.
Thank you very much. My question goes to the two ladies. Apart from establishing the clubs, how else did your project meaningfully engage the adolescents and young people, particularly in the design, implementation, and review? And also, have you labored to share the lessons learned with the beneficiaries? And if you've done so, what specific actions or lessons have they picked? And have there been any commitments towards taking actions, particularly for the young people and the adolescents? Thank you.
Great questions. Well, Colleen, it's all yours.
Okay, so I'll try to answer a couple of those questions, and I think they're also relevant to how our project is designed, because that's interrelated with how we measure. So I might refer some of those hot topics to Emmanuel. I think on the question with disabilities, that's an excellent point, that that audio assistance component of those surveys is also relevant to those who are visually impaired. I think a step further that we could have taken was to really utilize that as an opportunity to test different methods for the visually impaired or other types of disabilities in that survey. And I hope we're able to do that in the future. I think that it's an approach that could be translated into a project focusing more thoroughly on adolescents with disabilities and adults with disabilities. We do collect some demographic information on the disability status of our respondents. But I would also note that I think for measurement, disaggregating by disability can be a challenge. A challenge because adolescents aren't always willing to self-report that they have a disability, maybe are not cognizant of the type of disability they have. And the disabilities that enumerators are able to identify are often physical, visible disability. And so that excludes kind of the wider definition of disability. So I think that's a measurement challenge generally, but also presents a challenge to our project to do better at addressing that. So thank you for that. Did you want to say anything about design, or should I move to the other question?
Sure. I think in terms of engaging the adolescents in the design of the project, not in the initial design or write-up, but of course before we went into any intervention, we did our baseline. We are still talking about the baseline. And as part of the baseline, we have done extensive qualitative assessment with focus group and key informant interviews. And of course, Dominique can talk about that more, but we have done multiple groups of focus group interviews or focus group discussions with boys, with girls, with young women. So the program is informed by what we heard from them, in addition to some of the limited data we had as part of the household survey, which also included some data on adolescents. So in a way, their input is factored into what we plan for our programming.
So I'll just answer briefly the other question on adolescent measurement out of school, Erica's question. Thank you for that, Erica, and then I'll probably hand it over to you, Dominique. Yes, great point. So as I spoke about, it's difficult to access adolescent populations. We often find that they're missing it at the household level because they're at school or employed or whatever it may be. Timing of day often affects that as well. In this project, we, at least for the pilot in Bangladesh, we don't have a relationship in this project with the Ministry of Education. So those adolescent groups are not necessarily associated with school bodies. And what that meant was that we needed to consider, if not at school, then where? And we tossed a lot of options around. Should we conduct a snowball sample where they refer us to other adolescents they know? Could we randomly sample adolescents in the community? What would it take to find them all? And I think what we settled on was that within our available resources, the best way to access adolescents was via the clubs that were formed under the project. There were some confounders we needed to control for around had those adolescents participated in other clubs, what information had they already received, but we ended up randomly sampling from adolescent boys and girls that we could find through those clubs. So that was our point of access.
meaningful participation, just a few thoughts. There's a lot of things and issues there, but I'll just touch upon a couple of points. So during the baseline survey, as we mentioned, we couldn't talk to unmarried adolescents as part of the household survey. So what we did is we had made sure to have focus group discussions with them to hear what they had to say. And something we did during the baseline was to develop some guidelines on what we call gender responsive data collection. So these were, 7, 8 pages of guidelines of what do facilitators and enumerators and data collectors need to do to make sure that the spaces in which we collect the data are safe for adolescents, for girls, for all beneficiaries. So, we encourage them, for example, in the focus group discussions to have female facilitators with female groups, male with male groups. We wanted to make sure that there are, sex-segregated toilets that are clean, make sure that the locations where we would have these focus group discussions was available and safe. So that's a way we try to encourage a little bit the meaningful participation of women and girls in that data collection process to make sure that they would feel comfortable to participate in these spaces. Because the worst is to have a focus group discussion where you have one person who speaks all the time and nobody else there speaking. So we really did everything we could through these guidelines and through training of enumerators to make sure that these issues would be addressed. Something else on meaningful participation during implementation. So I think the clubs are a really good place for that. The girls and boys, they learn a lot of things in these clubs. As I was mentioning earlier, there's a lot of, we want to fill that information gap about SRHR that is so important for youth to be able to make informed decisions about their lives. We have a big focus on leadership skills, decision-making skills. So, we have trainings where, girls will learn, okay, and boys will learn, okay, what does it mean to be a leader? What does it take to be a leader? How do you exercise leadership? When can you exercise leadership? So that gives, I think, a lot of food for thought for adolescents to try to see themselves maybe in roles that they had not thought about before being engaged in these clubs. So that's one of the things we're doing to try to encourage their meaningful participation in the club, but also outside of the clubs within the society. In Mali, I was just talking to my colleague there last week, and she was telling me that there's a bunch of girls now who are basically going to their school principals and asking them to organize some information sessions on preterm birth at school, because now they have all this information and these skills to deliver it, and they want to use it. So they want to feel responsible about something. So that's an example of how meaningful participation is happening. So maybe I'll stop there for now because I see we have other people that want to ask questions.
We have about 1 minute left. So I see 2 people standing. If you have very short, quick questions, then feel free. Otherwise, come and speak with us after. But.
Well, it's a question, maybe it might stay open, and I'll keep on thinking about it in our respective projects. My name is Erica Moorkirk, and I work with CCISD in Quebec City. And, we all are involved in projects. Projects come and go, just like all the NGOs we work with come and go. And I was wondering, and I know you won't have time to answer in a very lengthy way, but you've talked a little bit about it, about engaging participation in implementation and such, but and you've talked a little bit about how you engage certain key stakeholders to create that enabling environment that is really necessary to help change happen in a way. But could you tell us a little bit more about what you do in terms of developing ownership? It's all very, very well to design all these tools and things, but how if things really are going to change, people need to have that sense of ownership. Otherwise, nothing's going to happen. It's not theirs, so why would they be motivated? And that, from the adolescents to the rest of the environment to the institutions that you're dealing with. So I know it's a big question, but I'm really curious as to hear more about what it is that you do to support or to help develop that sense of ownership with your partners and beneficiaries and stakeholders. Thanks.
Okay. Someone has 10 seconds.
You've already said it's. We probably can't give a long answer to this, but in the next few seconds, just to give you a sneak peek of what we are doing to create that ownership on the ground, I will just quickly give you an example from Ethiopia. where we use male engagement as one of the approaches to address the gender inequality issues, which also is very relevant to adolescent sexual reproductive health. And last fall, I was in Ethiopia visiting our program on the ground, and I was quite moved by the transformation that's happening as a result of that male engagement, a very structured conversation of about 8 sessions in a span of, I think, 2 months or so. And then they consistently engage and they hold each other accountable for the change, and to hear some of the testimonies from the couple, the women talking as to how their husbands have been transformed and their attitudes, and how they have started to take care of their children, how they've started to help them there with their household chores, and then the testimonies from the husbands themselves. And then the religious leaders, the extent to which they have taken ownership of all of this transformation was quite moving. So for me, that's just the beginning. We have covered, I think, about 1,100 households in that conversation. That was just in a few villages, and the plan is to scale it up, not just in Ethiopia, but we are doing the same in all the 3 countries. So this is just one small piece of it.
Great, thanks, Emmanuel. Sorry to cut you off, but so that's just one example of how we can create ownership. I agree, that's a great question, and please do come up and speak to us as a panel afterwards. I'd want to thank you all for listening and participating. I hope that you found it useful and that you can take lessons from there. I would just finish with something that Peter Singer said in the plenary. One of the frustrations is around a call to action where there's no action. And so if you've come here and you think, oh, that's very nice, and then you don't do anything as a result of being here, then this has just been a waste of time. So I really challenge you, what are you going to do next, and what are you going to do differently as a result of what you've heard here today? And one opportunity I would throw out to you is that in July in Toronto, UNICEF is convening a 2-day summit on community adolescent health innovations. And we're looking for people who can bring knowledge, influence or resources to help us solve 3 to 4 key challenges. If that's something that you think you could add value, then do come and speak to myself afterwards, but also do come and speak to our panelists here about the amazing work that they're doing in these 3 countries. And thank you so much.